we're going to be sending out a survey, sending out a survey and all those good things, and thank everybody and kind of close the call out. So just be mindful of your time. And I think that's it. Thank you all for being here and presenting. I think, yeah, last time I got a number, it was 90 folks registered. So, you know, that means that we might have 50 on the call, but hopefully a little bit more.
And people can always watch the video afterward.
Exactly. All right, Michelle, you want to let folks in and then we'll get started in about 30 seconds so that we stay on time. Folks always trickle in a little bit later. Good afternoon. Welcome. Thanks for being on the call with us today. We'll wait about 30 more seconds to let some more folks join us. I know it's just right at the top of the hour, so that number is moving pretty rapidly, but thanks again for being here. All right, good afternoon to everybody still joining us. Thanks all for being here. We are here for our third session of our three-part series, Navigating the Complexities in Blood Cancer Diagnosis and Care Across Varying Community Cancer Care Programs. That's a mouthful. And session 3, we're really going to be focusing on that returning to care in a community cancer care program, continuing shared care, survivorship, long-term care, and end of life. This webinar is brought to you by our ACS Hematologic Cancer Collaborative. Michelle, would you advance the slides? Because I think my my clicker over here is just not working in real time today. Back one. Can you go back one, please? Sorry, folks. Zoom has a mind of its own. I'm sure you all already know that. Michelle, are you able to go back one, or is Zoom just seriously taking over our slides?
Jesse, I think you have control of the screen, but
Yeah, mine is not working. If you're able to take control and move that, I would appreciate it because
okay, let me see if
it's
I
not
can.
working for me. So we just need to go back one. Thanks for your patience, all. I know I'm not alone in feeling like, Zoom is taking over. All right. Again, thank you all for being here. I do want to really send appreciation to our sponsors that support our ACS Hematologic Cancer Collaborative, Sanofi, Kite, Blueprint, Syndax, Genentech, and Takeda. We really appreciate your support of our collaborative that helps us do this great work. Next slide, please, Michelle. I'm going to introduce Dr. Agrawal. He's going to help moderate the call for us today and introduce our speakers. And just a little bit about him. He's a pediatric hematologist, oncologist, and bone marrow transplant physician. He joined the American Cancer Society in May 2024 to oversee ACS's global cancer support programs, which span the cancer continuum from cancer prevention and screening to patient support with education, patient navigation, to healthcare provider support and health system strengthening. While he was at UCSF, Benioff Children's Hospital, from 2014 to 2024, he developed and directed the early phase and cellular therapies program. He also developed Southeast Asian pediatric hematology oncology in 2016 to improve pediatric cancer outcomes in Vietnam, including initiating a 2-year master's level training program. He was the medical director of pediatric hematology oncology and Gaborone in Botswana as part of Texas Children's Cancer and Hematology Center from 2011 to 2012, and a pediatric AIDS corps physician as part of the Baylor International Pediatric AIDS Initiative in Maseru, Lesotho, from 2007 to 2008. And we are also very grateful to have Dr. Agrawal serve as an ACS Hematologic Cancer Collaborative Advisory Committee volunteer. And with that, I will hand the mic over to you.
Thanks, Jesse. Really appreciate that introduction. And thanks everybody for joining this session. It's really been my pleasure to participate as a medical advisor for the Hematology Collaborative. You can go to the next slide, Michelle. So the Hematology Collaborative started in 2024 with 34 multi-sector partners that worked over 4 meetings to establish a set of strategies and activities across 3 focus areas, which are developed through our working group meetings and are included here. So addressing equitable access, managing complexities, and enhancing the blood cancer care experience. In 2025, have worked to distill the strategies and activities identified in 2024 and create actionable projects and resources to improve the blood cancer care experience for patients and their caregivers after they receive that diagnosis. So this webinar series is one of the deliverables as part of those initial goals. You can go to the next slide. So it just shows pictures and now the list of all the volunteers who have been participating in this work. A really huge thank you. This is all volunteer work that everyone is taking upon themselves in addition to all of their regular work. This is a list of our 2025 partners, most of which were also with us in 2024, and really provide multi-sector experience, academicians, researchers, patient advocates, persons with lived experience, all really vital for us to do this work together and to think about how do we address this really complex multi-sector, multifactorial issues together. You can go to the next slide. So this is the third part in the 3-part series. Again, trying to address some of those initial goals that came out of the Heme Collaborative meetings. So this is specifically in regarding to how do we navigate some of the complexities in the diagnosis and care of a blood cancer patient, thinking about patients that are needing to transition between community oncology practices to academic centers for bone marrow transplant potentially, and then back, and then also potentially transitioning to palliation, end-of-life care, or survivorship. So this is the 3rd session in that series, and the first 2 sessions, which are included here, were completed last year in October and then January this year. Thinking about the initial treatment paradigm for patients with blood cancers. The second was, how do we think about what are the models for shared care for patients that are potentially going between or transitioning care between a community center and an academic center. And then today we're going to focus on returning to care in a community cancer program and really thinking specifically about survivorship, palliation, long-term care, and end of life. So thinking about some of those themes and providing some models as how this can be done successfully. And also recognizing there's many gaps still that we're working to address through this webinar and other modalities. You can go to the next slide. So today we're going to talk about 3 areas, and then we should have a little bit of time at the end for Q&A as well. So if you have any questions, please feel free to add them to the Q&A box. I'll be moderating that session with our speakers. So our goals today are to understand the complexities of transitioning patients back to the community center, identifying some of the gaps and also some of the strategies to strengthen both survivorship and long-term care, identify the end of life and palliation challenges and some of the strategies to address those as well within the community setting. And then our third speaker will be able to talk directly about some of her strategies from the community standpoint of managing transitions of care in all of these settings. And I think that will be a really good lead up to our Q&A as well. So we're really fortunate to have 3 esteemed speakers today. I'll introduce all of them prior to their initial talks. So again, really happy for them to provide their unique perspectives, also all having worked in complex settings and helping with transitions of care, which is a really important part of the discussion. So thank you again and look forward to your talks today. You can go to the next slide. So I wanted to provide this slide just to help us with framing. We're really thinking about expanding beyond our individual roles is how do we make changes that are going to impact the patients, us as providers, but then also recognizing the systems level changes. So a lot of the work that we have to do is to be advocates to support patients, recognizing where patients can also and their caregivers can be advocates, and where can we potentially impact system level issues. These are all things that are going to get worse as we have more and more resource limitations. Cancer incidence is increasing, intensity and length of therapy is increasing. And so, really thinking about it as these three interlinking blocks between what can be done at the patient level, what are the things that we're probably already doing at the provider level, and where are there opportunities for us to have impact within the system level. And our speaker is going to talk to, I think, all three of these levels. So I think it's, for me, an important framing when I think about the work that we try to do within ACS, both domestically and globally. I think also just recognizing that there are limitations, right? We're trying to make small changes to have big impact over time, and that um, we recognize that we're all doing this on top of all of our other work. And so we appreciate your participation. I think building awareness and identifying the challenges is a really great first step. And then trying to really highlight and use models of care that have worked across these environments will really help us going forward, such as models of shared care. Next slide. So now we'll be moving on to our speakers. So our first speaker today, really happy to have Dr. Betty Hamilton, who's an associate professor of the Cleveland Clinic Lerner College of Medicine of Case Western Reserve University, and a staff physician in the blood and marrow transplant program in the Department of Hematology and Oncology at the Cleveland Clinic. Dr. Hamilton's clinical and research interests focus on the treatment of hematologic malignancies with allogeneic hematopoietic stem cell transplantation and improving outcomes post-transplant, specifically in graft versus host disease and survivorship and quality of life. So really appreciate having you here today and look forward to the discussion, Dr. Hamilton.
Thank you so much. Can everybody hear me okay? So thank you again for that introduction. I'm thrilled to be here to talk a little bit about survivorship and shared care. For my initial talk on this webinar, I'm really going to be focusing on defining survivorship, describing sort of the wide breadth of late effects that our blood cancer patients experience, some of the gaps and challenges, in particular in different survivorship care models, and some ideas for the path forward to bridge some of these gaps. I am also a transplant physician, so a lot of the data that I'll be going over is in transplant patients. These are my conflicts of interest. So, as many of us are well aware, the number of cancer survivors, including blood cancer survivors, is rapidly increasing and expected to continue to grow. Not only are the number of cancer survivors growing, but the duration of how long these patients are surviving is also growing. Patients are diagnosed earlier, are now living longer, and so all of this is creating a large number of long-term survivors to care for. First, what is cancer survivorship and how is it defined? So we now define cancer survivorship as the health, well-being, and quality of life of people living with cancer, from diagnosis to treatment at the end of life. As I just showed in the last slide, the number and duration of survivors are increasing, and cancer survivors now represent a substantial proportion of the US population. Importantly, these patients are very heterogeneous in regards to their diagnoses, treatment history, toxicities and side effects to therapies, their prior comorbidities, life experiences, and behaviors. And we, as hematologists and oncologists, are increasingly caring for these patients. And so there's really a critical need to address the best approach to shared care in this growing population. Sorry, my clicker froze. Okay. So just to illustrate some of the data in blood cancers, what this table is showing just that the probability of 5-year relative survival in the United States for these different blood cancers has greatly and significantly improved over these several different time periods. You can see here, particularly in diseases like leukemia and multiple myeloma, there's been a drastic improvement in survival rates. And this is really due to the advancements of our therapies, our novel targeted therapies, and safer and better approaches to treatment, transplantation, as well as some of the more novel cellular therapies like CAR T. Survival improvements have also been demonstrated in transplantation. This is data from the Center for International Blood and Marrow Transplant Research that demonstrates significantly improved survival in these 5 to 6 year time periods over time. But as we know, as transplant strategies, our supportive care measures, and overall efficacy of transplant continues to improve, the number of transplant survivors also continues to grow, with an expected over 500,000 by 2030. Transplant survivors, however, continue to remain at risk for long-term late effects long after the risk of disease relapse decreases. The risks of these late effects can vary over time, and tracking and managing these can be challenging because of the transitions of care away from the transplant center. This data on the right demonstrates that in a large cohort of over 4,000 survivors of allogeneic transplant, disease-related mortality and non-disease-related mortality diverged sharply after 5 years. Data from large BMT survivor studies have shown that both the transplant that have data on both transplant recipients and their siblings demonstrate that nearly 2/3 of patients report at least one chronic health condition compared to only 39% of their siblings. Additional data has demonstrated that life expectancy among 5-year survivors is about 30% lower than the general population. So while there are a number of complications that we know can occur early after transplant, especially in allogeneic transplant, showing the risk of acute and chronic graft-versus-host disease, these often occur in the first year to 2 years of transplant. We now know that long-term survivors are at increased risk for a number of late effects, including lung, eye, hormonal, and bone effects, and in particular, increasing risks of cardiovascular disease and second malignancies. Several studies have demonstrated a significant impact of late effects in survivors of blood cancers. This is just one example of an international cross-sectional study of long-term AML survivors, which demonstrate that compared to the general population, AML survivors have clinically relevant impairments in physical functioning, had a high prevalence, 88% of comorbidities, had poor quality of life, particularly in transplant recipients. And in regards to lifestyle behavior, 66% were physically inactive, 80% did not meet dietary recommendations, and over 55% were overweight or obese. Now, why are blood cancer survivors at such risk for so many late effects? There are many factors that can influence this, including the disease itself, the different therapies, including immunotherapy, transplant, cellular therapy, that then can impact things like hormonal dysfunction, cardiovascular risk factors, endothelial injury, and sequelae of immunodeficiency that then subsequently lead to a variety of late effects. But also importantly to note is that the patient's prior history, genetic susceptibilities, environment, and lifestyle behaviors all can influence this as well. So what do we know about the care of longer-term blood cancer survivors after transplant? This is data again from another BMT survivor study of over 3,000 adult patients that were transplanted between 1974 and 2014 that survived at least 2 years post-transplant. And as you can see on the figure on the left, healthcare utilization really declines over time. So less than half underwent any routine checkup, and these are survivors 20 years post-transplant. So less than half underwent any routine checkup. Only about 37% had a BMT-focused visit, and only 29% had a visit at their cancer center. In contrast, 1/3 of transplant survivors on this graph on the right, more than 20 years out, reported still at least one emergency room visit in the 2 years prior to this study participation. And really, if you can see, this decline in healthcare utilization really coincides with the prior graph, in which we see that there's a marked increase in many late effects, such as second cancers and cardiovascular disease. And these are things that require longer term follow-up. And it's presumed as survivors survive longer after transplant, they may view their disease as cured, and they may underappreciate the need for continued surveillance of late effects. And unfortunately, as the risk of chronic health conditions increase, risk-based care declines. Similarly, this is another study that assessed the transplant survivors and the number that were seeing their primary care physician, as well as their adherence to recommended preventative medicine and health maintenance. And this graph on the left just shows that, before transplant, 75 to 80% of patients had at least one annual visit with their primary care. But by the 5th year post-transplant, 36% did not see their primary care at all. And then on the right, these graphs are just demonstrating that routine health screening were really quite low in the range of 20% or so, with cholesterol, diabetes, breast cancer screening, cervical cancer screening, and colon cancer screening. And just to highlight the importance of the return to sort of community care, which is oftentimes more focused on wellness care, this study also demonstrated that risky health behaviors such as smoking, heavy alcohol, and lower physical activity were all associated with worse survival. Importantly, I just wanted to highlight one of these qualitative studies of young adult survivors of blood cancer that explored factors and themes which impacted survivor engagement with their own survivorship care. And while they found that survivors were more likely to engage with continued care due to either late effects or mental health concerns, there were definitely clear barriers to care, including cost of care, travel logistics, and you could say about 50% delayed or foregone care due to the cost. So I'm going to talk a little bit about some different care models and general survivorship care. So in 2006, a seminal report from the U.S. Institute of Medicine identified essential components of survivorship care. And this included recommendations for surveillance of recurrence or primary cancers, as well as new cancers, prevention of recurrent and new cancers, as well as the plethora of late effects, management of late effects, including symptom management and psychosocial effects, coordination of care. And a key recommendation from this report was that all patients should receive a survivorship care plan, which can summarize patients' diagnosis, treatment, details around recommended follow-up strategies to remain well, and a list of support resources. So there are many, many different models of survivorship care that have been described and proposed, each with many relative pros and cons. Many are focused in some way on a hematology oncologist specialist, while there are some that have been focused more on primary care or community care. It's clear from the literature that there is significant heterogeneity in the field, and there's really no one-size-fits-all model. There's no evidence that one model is more effective than the other. Unfortunately, regardless of model, there's still really many concerns regarding lack of communication, coordination, fragmented care, lack of training, and ultimately unmet patient needs. I'm just giving an example of how we deliver survivorship care at our academic center, and this is largely focused on allogeneic transplant recipients. So we start with pre-transplant assessments to obtain baseline assessments, as well as, which I consider survivorship assessments as well as the routine assessment of organ function and psychosocial support. After a patient undergoes a transplant, a formal survivorship visit is done relatively early at day 100 to provide several further assessments, including lung function testing, multidisciplinary care with nutrition, pharmacy, social work, as well as specific evaluations for things like bone health, neurocognitive screening, physical functioning, and metabolic syndrome evaluation, things like height, weight, BMI, lipids, glucose. These survivorship visits are done then at 1 year, as well as subsequent longer term follow-up, especially if they have specific complications like graft versus host disease. Um, so we've used specific focus guidelines and updated these based on the updated 2023 ASTCT International Survivorship Guidelines. We provide each patient with a survivorship care plan, which details follow-up testing, frequency, who might be responsible for this testing, which can vary from patient to patient, and when it is due. I certainly acknowledge this really requires a high resource, dedicated team of coordinators, nurse coordinators, nurse practitioners in coordination with the transplant team. And we still acknowledge several gaps. This is something that we can do here at our transplant center, but can be more challenging to do, for example, in our autologous transplant recipients or CAR T recipients who return to the community. Essentially, the goal, though, of this is to really empower and educate patients in their own survivorship care. But this, of course, can also be challenging depending on the patient and their resources. And I highlight here just some key areas that I think are critical to further work on and consider in survivorship care as it continues to expand to increase patient engagement with the use of things like patient-reported outcomes and health trackers, better coordination with the community using our electronic health record or other approaches as well, and the use of things like telemedicine to be able to deliver more specialized multidisciplinary care when we need it. So in my last couple of slides, I just want to talk briefly about how we might consider advancing our ability to share survivorship care. And I want to go back to the definition of cancer survivorship, being from diagnosis to treatment at end of life. So in addition to the growing population of we traditionally think of cured cancer survivors, this population also includes a growing number of patients with advanced but non-curative cancers, such as multiple myeloma, that are living with much longer life expectancies. Importantly, providing survivorship care requires an approach that meets the needs of this growing population, as well as being sustainable for providers and healthcare systems. Several frameworks have been proposed, and this is one from back in 2016 from an NIH-sponsored late effects initiative that addressed survivorship care and transplant recipients. But I think it highlights many important principles in this conceptual framework, really providing a model for patient and caregiver-centered value-based survivorship care that has to consider accessibility, affordability, coordination with local providers or multidisciplinary teams. And survivorship care really should be dynamic and adaptable as patients' healthcare status can change over time. And of course, it has to be evidence-based, high quality, and individualized to patient-specific exposures and risk factors from both the pre and post-transplant period. And what has been proposed, and I think critical, is a personalized approach to assign patients to different care paths or risk stratification, ideally in a dynamic way. There are many things that can be included and need to be included in this sort of risk stratification, including risk of recurrence, late effects, ongoing chronic effects, psychological health, health literacy, and ability to self-manage, social and economic issues, geography, and also the capacity of the healthcare system as well. This is just from experience from the UK that demonstrated a successful implementation of a personalized approach to survivorship care, which is really dependent on risk. So those who are at low risk become on a path of more self-care with support and obviously access back to a more specialized care. Down to shared care, and then finally to a more complex model, which requires multidisciplinary specialized care. And this model in the UK and other single payer systems really has demonstrated that this has led to improved patient outcomes, more efficient healthcare utilization, and reduced costs. And finally, just a brief note that I think in this day and age, in the contemporary era, we're going to need to use technology to help accomplish all of this. Anything from using large data, machine learning to develop risk stratification models to the identification of patients in real time, tracking patients, care coordination, virtual visits, and facilitation of follow-up, and to also measuring outcomes as well. So in summary, I think we all know that the number of blood cancer survivors continues to grow. There's several care models that exist, but unfortunately, we yet still lack a standard. I do think that data supports a risk-adapted approach, and I think we all need to work together to come up with a multi-pronged approach to survivorship care. So with that, I thank you, and I think we'll take questions at the end.
Thanks, Dr. Hamilton. That was a really wonderful presentation and really highlighted some great models of care and, of course, gaps that we can work on together, as you said very well. So appreciate that. And we'll see what questions there are in the Q&A later, as mentioned. So I wanted to transition to our next speaker. Very happy to have Sarah Lowry, who is a palliative care oncology nurse practitioner with over 20 years of experience. For the last 13 years, she's been practicing at OHSU, the Oregon Health and Science University, within the Community Hematology Oncology Department. In addition to her clinical work, she serves as National International LNEC faculty. And for those who aren't aware, LNEC is the End-of-Life Nursing Education Consortium. So very pleased to have you, Sarah. Thank you so much and look forward to your presentation.
Hopefully this lag will be okay here. I'm very excited to be part of this webinar today. So I'll be speaking to the palliative and end-of-life needs for people. And there we go. And my only disclosure is LNIC faculty. And so, we'll start, Dr. Hamilton spoke a little bit about the unique needs of people living with blood cancers. I'll speak more to end-of-life symptoms. Anybody with an advanced cancer diagnosis is going to have a high degree of physical or psychological symptom burden, but there are symptoms that are unique to people living with hemalignancies. So it's going to be higher rates of neuropathy, cardiomyopathy, and fatigue. And then from a psychological standpoint, higher rates of anxiety, depression, PTSD, and fear of cancer recurrence. There's also much higher rates of healthcare utilization from the time of diagnosis to death for people living with an acute blood cancer. Over a quarter of their life will be spent in the hospital. Another 14% will be spent in clinic. And there's a substantially lower hospice length of stay compared to other oncology counterparts. There's also lack of advanced care planning and end-of-life discussions, which we'll speak to in a couple of slides, and we'll speak more to some of the reasons for the low hospice referrals and lengths of stay. And there's a lot of barriers that exist to early engagement with palliative care. The disease-related barriers include the unpredictable disease trajectory, the chance of cure even with recurrent or relapsed disease, and the high rates of morbidity and mortality associated with intensive treatments, as well as an unclear transition phase between curative and palliative treatment. Systemic barriers, there's a shortage of palliative care clinicians that's even more pronounced in community and rural settings. And a lot of the early literature on the benefits of palliative care excluded people living with heme malignancies. There's also clinician-related barriers. Over half of transplant physicians equate palliative care to end of life, and over 2/3 feel like just saying the word palliative care decreases hope for patients and their families. But over the last 10 years or so, there's been increased literature on the benefits of early palliative care involvement for people living with blood cancers. A lot of this is led by Dr. El-Jawari and colleagues. And what they have found is a scheduled inpatient palliative intervention for people admitted for transplant can improve quality of life and have a significant improvement on psychiatric symptoms related to transplant, even 6 months after transplant. And so I think this is a perfect example of how a palliative care team isn't necessarily only focused on end of life, but can also help people live their life as well as they can within the confines or context of the illness that they have. There was also much higher rates of advanced care planning documentation and less chemotherapy in the final month of life. But as you'll notice here, there was no difference in hospice utilization or length of stay. Or no decrease in the number of deaths happening in the hospital. So you might wonder, what is it that the palliative care clinicians actually did in these interventions? They visited with people twice a week while they were hospitalized, and the most common interventions included establishing rapport, addressing symptoms, most commonly nausea, pain, and diarrhea, and helping to support coping. So when we think of what are some of these interventions that we can do when patients are back in their home communities? Well, advocating for early referrals for palliative care involvement when somebody's going to be admitted in an academic medical center, when they're admitted for transplant, letting the team know early palliative care can have downstream effects even after the patient returns to their community. We also know that people post-transplant highlight a perception of communication breakdowns between the healthcare systems, between their specialists and community providers, and what are ways that we can help support that strong two-way communication. I know that Dr. Okolotako is going to talk also about ways to reduce the time burden that people have in terms of, going back and forth for some of these survivorship monitorings that Dr. Hamilton mentioned. One thing that I utilize, especially when my time is constrained, is something called the ESAS, or Edmonton Symptom Assessment Scale. This is a 0 to 10 Likert scale that asks people to rate severity of some of the 10 most common symptoms that people living with cancer experience. And so having somebody complete this at certain intervals before their appointments with you is a quick way to just 3 seconds as you're walking in the door, get a sense of what symptoms, either psychological or physical, are the most distressing to your patient at that moment that could then guide the conversation and potential interventions for support. But one of the most common symptoms that people deal with are fatigue. And when we think about what are the interventions that we can do for fatigue, a lot of it is based on their goals of care and where they're at in their disease trajectory. If somebody is nearing the end of their life, we might be focusing more on energy conservation strategies and how do we help support that limited energy being spent doing times that are meaningful for you. Whereas alternatively, if somebody's new in survivorship or their disease is in remission, there's increasing literature on the benefits of structured exercise and strength programs in terms of fatigue and just health-related quality of life. Helping to support coping, this is whether it's problem-focused like logistics and planning, or emotion-focused like helping people to build the resiliency skills. And this is somewhere where your nursing or social work colleagues can help support. But I think one of the things that we do the most often are transfusions. When somebody is anemic, they are fatigued, and when they are transfused, they have a transient improvement in their fatigue. And this is one of the biggest limitations to the engagement with hospice, especially when somebody's nearing the end of their life. We think about hospice as interventions to support somebody living the best quality of life they can while they're in their final days to weeks to months of their illness. And sometimes people might say that we don't do transfusions on hospice because transfusions are life-prolonging. But anybody that works with people with blood cancers know that blood transfusions are also one of the best interventions to help support quality of life and energy. And people have to give this up right now to be able to access the benefits of hospice. So this is a pretty profound trade-off that our patients with blood cancers have to experience that others don't. So a few years ago, there was the Medicare Care Choices model, which was a pilot project where patients were able to access hospice services while still receiving conventional treatments for their life-limiting illnesses. So an example of this could be receiving blood transfusions while they were on hospice for their heme malignancy. And this map shows all of the different hospices throughout the country that were part of this pilot project. And what they found was that there was a decrease in aggressive medical interventions at the end of life, decreased healthcare utilization, and associated decreased Medicare expenditures, while also having higher hospice utilization, numbers of days at home, and also increased hospice utilization by historically underserved groups. So if lack of access to blood transfusions was no longer a barrier for people living with blood cancer, we would imagine that they would also get these benefits of being able to have both transfusions and hospice concurrently. Now, unfortunately, CMS didn't expand this model, citing concerns about generalizability. But this is one of the things that organizations like ASH have been advocating for several years. So there was a bill that was introduced in the Senate in 2021 that went nowhere. And this bill has been reintroduced last summer, and it has yet to get past committee. But this is S 1936, focused on improving access to transfusion care for hospice patients. And these are the representatives that have sponsored this bill. So since it's been there since last June and hasn't made it out of committee, it's highly unlikely that it will actually go anywhere. But I would highly encourage you to reach out to your representatives and ask them to co-sponsor it in hopes of getting it moved for meaningful change for our patients. So I feel like we can't talk about supportive care, palliative care at end of life without talking about how we care for and show up for our informal caregivers. And even just saying informal feels discrediting to the work that these folks are doing. So many of the interventions that patients receive would not be accessible to them without having a solid care support team at home through friends or family. And oftentimes that work behind the scene goes unacknowledged by the medical team. So I think it's really important that one, we just acknowledge that, but how do we help support them in being sustainable in the work that they're doing? So that could be including comprehensive psychosocial assessments of patient caregivers throughout the process, connecting them to support groups, and doing our part to make sure that we are ensuring care continuity between institutions. And then going forward, what can we do? So how can we help to improve ongoing, evolving advanced care planning and goals of care conversations? These are learnable, teachable skills. There's programs like Vital Talk that can help you learn and strengthen these skills. There's also the Oncology LNEC APRN course that's grant funded that helps improve primary palliative care skills for oncology advanced practice nurses. And then also focusing on building community. So if you are out in a location where you are the only person doing the work that you're doing, how can you connect to people throughout the country through special interest groups or communities of practice where you can share experiences so that we could all work together to do better and be more for our patients. And then I've just got my email here. Please feel free to email or reach out at any time if I could be of help. Thank you.
Thanks, Sarah. That was a really awesome talk, and really appreciate sharing some of those resources and also recognizing the significant caregiver burden, which is a key area of focus for us here at the ACS as well. So I appreciate that and look forward to some questions in the Q&A. I wanted to then transition to our final speaker. Thank you, Dr. Onyema Okolo-Taku, as a medical oncologist and hematologist at Ironwood Cancer and Research Center in Phoenix, Arizona. She completed her fellowship at the University of Arizona Cancer Center and a secondary fellowship in integrative medicine at the Andrew Weil Center for Integrative Medicine. She takes great interest in infusing evidence-based integrative practice into the care of her patients. I really appreciate that. We love integrative medicine. And outside of the work, she is a wife and mother of 2 toddler boys. She enjoys reading, traveling, and trying new foods. Thank you so much for joining us today and look forward to your talk.
Thank you guys so much for having me. I am trying to advance the slides. Okay, perfect. I don't know if I did that, but if I did, then everything is great. So I am going to start by presenting a patient case. We're going to be kind of putting everything together from what we have heard from Dr. Hamilton and NP Lowry about how this transition is important and necessary, and kind of putting it into a practical perspective, utilizing a patient case from my practice. So I work at Ironwood Cancer and Research Centers here in the greater Phoenix area. And although it is in Phoenix, which is a big city, for anybody who knows kind of the layout of Phoenix, we are very spread out. And so we have issues where sometimes a patient, although might have a quote unquote, Phoenix address, it could take over an hour to get from one point to the other. So Ironwood, we do have multiple locations throughout the Phoenix area, and it does make us more easily accessible to patients compared to some of the academic institutions in the area. We provide a lot of multimodal facilities, including medical oncology, radiation, breast surgery, gynecologic oncology, and integrative oncology. We're lucky to have a lot of ancillary support as well. This includes our own infusion, our oncology nurses, social work, dietitian, genetics counseling, and research nurses. We engage in participating in clinical trials. We're able to perform our own imaging like PET scans and CTs, but we do have certain limitations, including we do not have our own lab or phlebotomy services. Unlike academic settings, which who may have, in hospital hematology and oncology services, allowing them to kind of work, 7 days a week. We are limited to a Monday through Friday schedule, and we do not have our own hospital, so we work only as consultation services. So in this regard, being able to partner with a reliable academic center allows us to continue to provide high-level care to our patients, especially in our heme malignancies, where so much of the treatment nowadays includes things like transplant, whether it be autologous or allogeneic transplants, upcoming things like bispecific treatments, and of course, things like CAR T cell therapy. So these are all modalities that more often than not require patients to be monitored more constantly, or may require the patient to be in a hospital setting. And so really having a great partner in an academic institution is vital for us to be able to continue to take good care of patients. So I'll start by discussing one of my patients. This was a 67-year-old woman, presented to me initially in 2023 because her primary care doctor noticed an elevation in her serum protein. So our initial consult took place in November. She had bone marrow biopsy completed a few weeks later that did confirm a diagnosis of multiple myeloma, 80% plasma cells noticed on that. And so the initiation of treatment was delayed a little bit per patient preferences. As you can see, end of November was close to Thanksgiving, and having just received a cancer diagnosis, she wanted to at least go and spend some time with her family over the holidays. And so we didn't begin her induction until after New Year. So in January, she was initiated on RVD, and then with cycle 2, we added daratumumab for her. We noticed response on her, and by cycle 3, I made the referral to one of my academic partners at Mayo Clinic here in Phoenix. She had our first consultation in mid-March due to that good response from induction. And at that point, she was deemed to be a great candidate for consolidative autologous stem cell transplant. She completed her 4th cycle of DRVD in early April, and by early May was fully transitioned over to the Mayo team in Phoenix. She had her transplant in June, and she did have some complications that were revealed, unfortunately, due to the stressors associated with transplant. She developed atrial fibrillation. She did end up with some infections, particularly pneumonia and respiratory type infections. And so she did have a prolonged hospitalization, which is not typical in the autologous transplant patient. She was transitioned back to me in mid-July, and we did 2 cycles of consolidative treatment, and then she started on maintenance therapy, which she has been on since October 2024. So this is a very typical timeline for me for a lot of my patients with multiple myeloma, and is very similar for some of my patients with lymphoma as well. So why is it important to transition our patients back to the community? For many things, the biggest thing is convenience, and the secondary is going to be patient preference. A lot of the academic institutions are located in very kind of big hub city areas, I would say. And like I mentioned, technically Phoenix is considered a big city, but somewhere like Mayo Clinic is going to be, in downtown area, and we have patients that live over an hour from that space. So this is a huge reduction in their travel burden. And then they also are allowed to continue care with other local providers and not just their oncologist. A patient who lives in one particular area is going to have their primary care doctor. If they have other health concerns, for example, chronic kidney disease or heart disease, they may also have a cardiologist and a nephrologist. And to be able to continue to maintain those relationships is especially important. And this allows for very streamlined long-term follow-up for the patient. So there are certain things that work well to ensure that smooth treatment journey. The biggest thing for me has been ensuring that I have really good trust between myself and the academic oncologist that I'm working with. We have to have a very clear communication, and we have to have a very good plan when it comes to that patient. And then, from the community standpoint, we have to understand our strengths, but also understand our limitations. We can't do everything, and it's important to not have to do everything. Like I said, for us, one of our limitations is kind of in the blood setting of laboratories and transfusion capabilities and hospital needs. And so to have a partner in the academic setting that have these capabilities is especially important to me. Now, specifics of the long-term plan as well as follow-up. So there are certain questions that need to be answered, and this needs to be answered well before the time in which the patient has transitioned back to community. We need to know when the patient needs to be seen periodically by the oncologist at the academic center. We need to have clear monitoring recommendations from the academic oncologist, as well as defined triggers to engage in a re-referral for that patient. We need to be able to discuss survivorship with the patient. And then we need to highlight some of the patient-specific challenges that were either present before transition to the academic center or that developed after. Like I mentioned with my patient, the development of atrial fibrillation, for example. So survivorship in the community setting, what does something like this look like? So for me, I like to provide my patients with a timeline on what survivorship actually looks like for them. This includes, specifically if we're talking about something like multiple myeloma, almost every patient who has multiple myeloma after their initial treatment, if that included autologous transplant, will have maintenance treatment. And this can be a very prolonged road. So that includes kind of mapping that out for the patient to understand what this actually means. As Dr. Hamilton showed, long-term data does show that, follow-up does tend to decrease over time. And this isn't something that we want to happen in certain, in all conditions, but in conditions where some sort of maintenance program is required. So the patient needs to understand the importance of things like this, as well as understanding what their surveillance visits will look like. As will this be physical examinations? Will this include imaging? Are they going to be required to have blood work? If and when might they need to have another bone marrow biopsy, etc.? One of the biggest things, though, is management of late toxicities, if this happens at all, and what supportive measures might be available for the patients to engage in. And this can include things that, for me, that includes kind of the integrative oncology options for them. But also, as the community oncologist, you probably have a better understanding of what services are available in your community and in places closer to the patient that they can utilize to help manage some of their late toxicities. This includes understanding of the need for infection prophylaxis, vaccination, and then in patients with things like graft versus host, this includes kind of monitoring some of the medications that they may have to be taking for continued control of that, or signs of symptoms that might mean that maybe things are not going as well as they should be. And so ensuring communication, not just with the academic center, but also being that connector between the patients and their primary care. Just like we expect good communication from the academic oncologist, that primary care is going to depend a lot on you to provide clear communication to them, because continued healthcare is needed, even with a cancer diagnosis. This includes things like their heart disease or their diabetes or their hypertension. So we have to be able to keep our communication open on both sides. So I kind of have this table with the 5 main points that I focus on when it comes to survivorship and long-term care plan. So that means, treatment summary for the patient, which should include things like diagnosis, a list of the medications that they've been on, potential toxicities and complications that might come up from some of their treatments. Again, that will include a surveillance plan and continued discussions during their office visits, when they're going to be having blood work, imaging, things like that. More and more, we're seeing the use of tests for minimal residual disease. So when that is applicable, and if the patient is somebody who would benefit from that kind of close monitoring. When it comes to management of late or long-term side effects, you're watching out for their blood counts. You're looking for more subtle things like fatigue, anxiety. These are things that you can also continue to help your patients with. Unfortunately, there's always going to be that risk for secondary malignancies associated with certain medications or treatments. For example, if a patient is on something like Revlimid, or if they got treatment with radiation, to the chest. These are risk factors for secondary malignancies, and something that you have to keep in mind when you are continuing your care of this patient. In younger patients, fertility considerations are also important. And as I mentioned before, infection prevention and vaccinations, continuing the protocols on the patient. And finally, a very clear pathway as to when to send the patient back, and ensuring that there is kind of a streamlined process for that patient. And then end of life considerations, many of which NP Laura has already discussed. This is something that has to take place both before and after the patient is seen by the academic institute. You have to highlight and understand what their goals actually are, what their values are, what they expect from their treatment, and when and if a referral to palliative care and hospice would be necessary. These are what you do before, but also very similar when the patient comes back. What was the end result of their transplant or CAR T, for example? Was it successful? Did anything adverse happen that needs to be taken care of? What if it didn't work? What's our goal now? So these are things that are active communications that need to be considered. And one of the things as a community oncologist that we can help with is the local support. In the patient's area, we are going to be more attuned to the local hospices that might be available for the patient. And so this is very important that you continue this kind of active discussion with the patient. And so just to conclude, wrapping up the case that I presented earlier. So my patient, she is currently on maintenance treatment and receiving monthly office visits as part of her maintenance infusions. And we do lab monitoring for her as well. One of her adverse reactions is that unfortunately she has had continued cytopenias and hypogammaglobulinemia. So she gets infusions with IVIG when needed. Because she does have atrial fibrillation, she's now on a blood thinner, and she does need to continue follow up with a cardiologist. And this was somebody that I was able to get her set up with, somebody who works very closely with me for my patients with hematologic malignancies and understands the side effects associated with certain oncology drugs. We maintain communication with the Mayo team, and she tends to follow up with them every 3 to 6 months. We have an illness action plan for her because we don't have a hospital. If she is not too ill, we recommend that she go over to Mayo because they have her entire health history and understand what needs she will have. And then just continued management of some residual adverse effects like peripheral neuropathy. And she works a lot with us in our integrative oncology team, utilizing things like acupuncture and massage therapy. We communicate with her PCP, and after every visit, I ensure that my office visit note is sent over to her primary care as well. And about every 6 months, I update her patient summary if and when she would need a printout or something like that.
Great. Thank you so much, Dr. Kolotako. That was a really wonderful presentation, and I think it really coalesced a lot of the prior discussions too. And I think you did an amazing job highlighting not only some of the challenges, but also a lot of the solutions in making sure that smooth transitions occur for these incredibly complex patients. So we did not have any QA questions, and thankfully that's good because we're nearly out of time. So I wanted to again thank all the speakers and thank the audience and just pass it back to Jesse to conclude.
Yes, thank you all again. Wonderful presentations. I'm sure we could have spent a couple hours like sharing your best practices and lessons learned with this group. We really appreciate everybody being on today and taking time out of your busy schedule to attend this webinar. And again, thank you to our speakers for putting the time and energy into sharing your best practices with our audience. For everyone, please do take the survey that's going to pop up as you close this webinar, and then watch for an email from us with additional resources and educational opportunities, and also the recording and the resource list from this webinar. Again, thank you all. We are close to the weekend, so I'm going to say have a great weekend, but we still have Friday to get through. Again, thank you all and take care.
Thank you. Bye.